Welcome to the Radonc Smart Review Head and Neck Cancer series.
It's great to be here. I'm really looking forward to this one.
Me too. We have, I think, a really fantastic topic lined up today. We're jumping into what might be the most, the most elegant topic in our field. We're covering episode 27, early glottic cancer. And we're really going to focus on, the nuts and bolts, fields, fractionation, and the thing that matters most to the patient voice preservation.
Yeah, and it's funny you call it elegant because I completely agree. People think of it as, simple, bread and butter, but they really underestimate it. When you dig into the evidence, the anatomy, the physics, you realize that early glottic cancer is, well, it's the prototype of a radiation-curable malignancy.
The prototype. I love that. I love that framing because it really is the original success story of radiation oncology, isn't it?
It absolutely is. I mean, just think about it. Step back and look at all of oncology. How many other cancer sites can you name where we routinely, day in and day out, cure patients with just radiation?
Right. No chemo, no surgery.
Just photons. And we're not just curing the cancer. We're preserving the organ. We are saving the human voice. I mean, that is just, it's a profound responsibility when you think about it.
It really is. And the stakes are so high because the outcomes are expected to be so good. I'm looking at the stats here. For T1 glottic cancer, you're talking about 5-year local control rates that are north of 90%.
Oh, easily. And even when you step up to T2 disease, which is a bit more advanced, you're still in the 70 to 80% local control range.
With radiation alone.
With radiation alone. And, you always have that safety net in your back pocket.
The salvage laryngectomy.
Exactly. For the small number of patients who do recur, surgery is still an option. But, and this is the whole point of our discussion today, our goal is to figure out how to never, ever need that safety net.
One and done. That's the goal. And that really gets to the mission of this session. We want to move beyond the average approach. I mean, any resident can memorize the fact that early glottis gets radiation. That's the easy part. But a strong resident, a real expert, understands why. Why are we using these very specific fractionation schemes?
Right. Why 2.25 gray per fraction? Why not the 2 gray we use almost everywhere else? And the other big question, why do we completely ignore the lymph nodes in the neck for this cancer when for almost every other head and neck site, treating the neck is standard practice?
And then you get into the physics. I mean, how do you actually design these fields to cover the disease but not underdose that tricky anterior commissure?
Which is such a classic mistake to make.
Exactly. Or, on the flip side, not overdose the posterior structures. So I think by the time we're done here, you, the listener, are going to have a mastery of the staging. You'll know the evidence for the optimal prescription. You'll be able to design opposed lateral fields in your sleep. And, crucially, you'll know exactly how to counsel your patients on their voice outcomes.
It's a great roadmap. Let's do it.
All right, let's jump in, and we have to start with the foundation, which is always anatomy, the geography of the battlefield. When we say the glottis, what are we actually talking about? What are the structures?
So the glottis is, it's deceptively simple. It's this very compact midline structure, but it's a little more than just the vocal cords themselves. It includes the true vocal cords, obviously, but also the anterior commissure.
That little V where they meet in the front.
Precisely. And the posterior commissure, where they meet in the back, it's a very tight little box.
A tight box, I like that.
And the anatomy here completely dictates the biology. And the single most critical anatomical concept for you to understand, for everything we're about to discuss, is the lymphatic drainage. Or, I should say, the profound lack of it.
This is the whole key, right? This is why we can get away with these tiny little treatment fields.
This is everything. The true vocal cords have incredibly sparse, almost non-existent lymphatic drainage. It's a total anomaly in the head and neck. When I think about the supraglottis, which is just millimeters above it.
Right, that's got rich lymphatics, drains everywhere.
Rich lymphatics, bilateral nodes, a high risk of spread. Then you look at the subglottis, just millimeters below. That drains down to the level 6, the paratracheal nodes.
But the glottis itself is just sitting there in the middle like an island.
It's an island. It's basically an immunologic sanctuary when it comes to lymphatic drainage. And that single anatomical fact is the entire reason we don't have to treat the neck. We don't have to chase nodes because the highways for them to spread they aren't there.
It's amazing how embryology from decades ago dictates our field design today. The fact that the glottis arises from different branchial arches, it creates these natural barriers.
It does. And that's why your field is going to be, maybe 5 by 5 centimeters, versus a tonsil cancer where you're treating the entire neck from top to bottom.
Okay, so we've got this unique anatomical box. Let's talk about who gets this disease. Moving on to risk factors. We talk about the usual head and neck suspects, HPV, EBV, alcohol, tobacco. For early glottic cancer specifically, what's driving the bus?
For this one, you can pretty much park the viruses at the door. We spend so much time talking about HPV in the oropharynx and EBV in the nasopharynx, and that's critical. But for typical run-of-the-mill early glottic cancer, we are looking at the old-school carcinogens.
Tobacco and alcohol.
Tobacco and alcohol. We're talking pack years. This is a disease driven by those combustible carcinogens directly bathing the vocal cords over decades.
So it's a completely distinct entity biologically. We are not checking P16 status here.
No, not at all. In fact, it's so strongly associated that if you do see a glottic cancer in a lifelong non-smoker, it's actually quite a rare event and you start to think about other things. But for your boards, for your daily practice, you should assume this is a smoking-related malignancy.
Let's ground this whole discussion in a case. I think that always helps. This will be our anchor case for the session. So picture this patient walking into your clinic. It's a 58-year-old man. He comes to you with a 30-pack-year smoking history.
Yep, that is the classic demographic, right down the middle of the fairway.
And his chief complaint is 6 weeks of progressive hoarseness. He tells you he's not having any trouble swallowing, no pain with swallowing, no referred ear pain, and when you examine him, you don't feel any lumps or bumps in his neck. No palpable masses.
Okay, can we pause right there on that history? Progressive hoarseness. That is the hallmark. And it's so important because the tumor is growing literally on the instrument of phonation. It's on the vibrating structure itself.
So they notice it right away?
Immediately. This is why these patients present so early. A tiny 2-millimeter lesion on the midcord will change the vibratory pattern, create airflow turbulence, and make the voice sound raspy. It's not like a base of tongue tumor that can grow to the size of a golf ball before anyone even knows it's there.
That's a great point. The anatomy is its own early warning system.
It absolutely is, and that's why we're so successful, because this symptom allows us to catch them at T1 so often.
So he presents early, we have a chance to intervene early, we move to the workup. The key part of the physical exam is, of course, the flexible nasopharyngeal laryngoscopy, the NPL. You're holding the scope, you're looking down the airway. What are you looking for?
Okay, so you're navigating down. In our case, the finding is described as a small exophytic lesion, little bumpy lesion, on the middle third of the right true vocal cord.
So you see the lesion, but just as important as what you don't see, what are the negative findings you're looking for?
Right. So crucially, you're noting that it does not cross the midline, and it does not involve the anterior commissure. You're really examining that V shape where the cords meet to make sure it's clean.
And why is that midline crossing so important from a staging perspective?
Well, that's what separates a T1A from a T1B. But honestly, the next part of the exam is even more important. The most critical part of the physical exam, mobility. You ask the patient to phonate, to say E, and you watch those cords move. In our case patient, the description is that both vocal cords move normally and symmetrically. They adduct perfectly. And that single finding is the pivot point for all of early stage laryngeal staging.
We're going to circle back to that staging in just a second, but before we do, we also get imaging. We order a CT of the neck. Now let me play devil's advocate. If I can see the tumor with my own 2 eyes on the scope, why do I need a CT scan? Why radiate the patient?
That's a great question. You need the CT to see everything you can't see on the scope. The scope gives you a beautiful surface map. The CT gives you the depth and the surrounding structures. You are specifically looking for cartilage erosion.
Is it eating into the thyroid cartilage?
Exactly. You're looking for deep invasion into the paraglottic space, which is the fatty tissue just lateral to the cord. You have to rule out pathologic lymph nodes. Even though the risk is low, you have to look. And critically, you're assessing for subglottic extension,
which can be really hard to see from above.
Notoriously difficult. You can get what we call the iceberg effect, where you see this little tip of a lesion on the superior surface of the cord, but the bulk of the tumor is actually carpeting the underside, down in the subglottis. A CT with contrast is mandatory to rule that out.
And in our case, the CT is clean. No erosion, no nodes, no subglottic extension. So we have all our puzzle pieces. Let's put them together and stage this patient. This is an area where I see residents get tripped up because the definitions are so specific.
They are. You have to be precise. Let's break down T1 versus T2. A T1 tumor is a tumor that's limited to the vocal cords. It might involve the commissures, anterior or posterior, but the absolute defining feature, the requirement, is normal vocal cord mobility.
And we subdivide that into A and B.
Correct. T1A is limited to one cord, like in our patient. T1B means it involves both cords.
Simple enough. So what pushes you over the line into T2 territory?
Two things can make it a T2. First, if the tumor extends outside the glottis proper, so it goes up to the supraglottis or down to the subglottis, OR. And this is when people forget. If the patient has impaired vocal cord mobility.
Okay, let's really dig into this mobility distinction. This seems to be the critical judgment call.
It is. Think of it as a spectrum. Normal mobility, which is T1, means the cords are perfectly symmetric. They clap together fully and briskly. Impaired mobility means one side is sluggish, it's lazy. It doesn't quite get to the midline, or it moves slower than the contralateral cord.
Just a little bit off.
Just a little bit off. And that finding alone, that sluggishness, is enough to upstage a patient from T1 to T2, even if the tumor looks tiny.
Why? What's the biological reason for that? Why does a lazy cord matter so much?
Because it implies deeper invasion. It's a surrogate for what you can't see. It suggests the tumor has infiltrated into the vocalus muscle or into the paraglottic space, and it's physically hindering the cord's ability to move. It's a sign of more aggressive biology.
Like there's gum in the gears.
That's a perfect analogy. The muscle fibers just can't contract and relax smoothly because they're being infiltrated by cancer.
And just to complete the spectrum, what if the cord doesn't move at all? It's just frozen.
If it's fixed, completely paralyzed, and doesn't move on phonation, that upstages the patient all the way to a T3. And that is a totally different disease, a different conversation, a different treatment paradigm.
Right. A fixed cord usually means it's invading the cricoid-retinoid joint or
the nerve, or it's just a massive tumor that has completely replaced the paraglottic space. T3 disease is much more aggressive and often requires chemoradiation or primary surgery. So being able to distinguish impaired, which is T2, from fixed, which is T3, is a really, really critical clinical skill.
Okay, so let's bring it back to our 58-year-old guy. Lesion on one cord, normal mobility, no nodes on exam or CT.
That makes him a T1A N0M0 glottic squamous cell carcinoma, stage 1.
And we get the biopsy back, confirming moderately differentiated squamous cell carcinoma.
And again, just to hammer it home, we're not worried about molecular markers here. P16 HPV, not rubbed. This is a classic smoker's cancer. The pathology is straightforward.
All right. We've got our diagnosis, we've got our stage, now we have to treat him. And this takes us to probably the most important evidence-based part of this whole discussion, the fractionation story. This is where the art meets the science.
Yeah, this is one of the most clear-cut, beautiful stories in all of radiation oncology. If you take away nothing else from this session, remember this. For early glottic cancer, hypofractionation is superior, period.
And when we say hypofractionation here, we're specifically talking about 2.25 gray per fraction compared to the conventional 2 gray per fraction. Why did we even think to test this? What was the rationale?
It's all about radiobiology. Glottic cancer cells, we believe, have the ability to repopulate quite quickly during a course of radiation. So if you drag out the treatment over 7 weeks, giving these little 2 gray fractions, the tumor cells start to divide and fight back, especially over the weekends and in the later weeks of treatment.
So you're giving the tumor a chance to catch its breath.
You are. By shortening the overall time and hitting them with a slightly bigger daily dose, that 2.25 gray, we overcome that accelerated repopulation. We're accelerating the kill and not giving them a chance to recover.
And the evidence for this is not just theoretical, it's level 1 evidence coming from the Yamasaki trial.
The Yamasaki trial, yes. Published in the Red Journal, IJROBP, back in 2006. This is a landmark, practice-defining study that every resident needs to know cold.
So walk us through the design. How did they set it up?
They took 180 patients, all with T1N0 disease, and they randomized them to 2 arms. Conventional fractionation at 2 gray per fraction versus hypofractionation at 2.25 gray per fraction.
And the total doses were a bit different too, right? They adjusted them based on the tumor size.
I did. For what they called minimal disease, they compared 60 gray conventional to 56.25 gray hypofractionated. For larger tumors, it was 66 gray conventional versus 63 gray hypofractionated.
So interestingly, a lower total dose in the hypofractionated arm, but a higher dose per day. That's a classic radiobiology question. What did they find? What were the results?
The results were, they were staggering. They were undeniable. The 5-year local control in the hypofractionated arm was 92%. In the conventional arm, it was only 77%.
Wow. That's a massive difference. We fight for, what, 2 or 3% gains in most oncology trials?
Exactly. This was a 15% absolute improvement in local control just by tweaking the fraction size. It's a huge effect. It basically rendered conventional fractionation obsolete for this disease.
What about the side effects? I mean, you're hitting them with a bigger dose each day. Did it fry their larynx? Did it ruin their voices?
Great question. For late toxicity, there was no difference. Voice quality was preserved. For acute toxicity, they did see more skin erythema, a bit more of a sunburn effect, in the 2.25 gray arm, which makes sense. You're hitting the skin a little harder each day. But the important late effects were equivalent.
So the takeaway is clear. Level 1 evidence, 2.25 gray per fraction wins.
It absolutely wins. It is the standard of care. And it's been backed up by other data, too. There was a Korean trial, KRG-OG0201, that did a similar comparison. They also found a strong trend favoring hypofractionation, with laryngectomy-free survival of 89% versus 78%.
So you have multiple studies from different parts of the world all pointing in the same direction.
Yes, it's a very robust finding.
Okay, so that's T1 lockdown. But what about T2? These are bigger tumors, deeper tumors. Do we treat them the same way? The big trial here is RTOG 9512.
The T2 story is a little more complicated. RTOG 9512 didn't look at hyperfractionation. It compared conventional fractionation to an even more intense schedule called accelerated hyperfractionation.
And let's just clarify for everyone listening, hyperfractionation is different from hypo.
Yes, very different. Good catch. Hyperfractionation means treating twice a day BAD. You give smaller doses, but you give them twice a day to get more total dose in over a shorter period. They compared 70 gray conventional against 79.2 gray, given in 1.2 gray BP fractions.
That sounds like a grueling schedule for a patient, coming in twice a day for weeks on end. Was it worth it?
Well, there was a numerical improvement in local control. It was 78% with the BID schedule versus 70% with conventional. But, and this is the critical part, it was not statistically significant.
So a trend, but not a proven benefit.
A trend, but not a proven benefit. And the BID arm had significantly higher rates of acute toxicity. The mucositis was much, much worse. Grade 3 and 4 toxicity was substantially higher.
So where does that leave us for T2 today? If BID is too toxic and logistically a nightmare, and conventional seems a bit underpowered, what's the standard?
This is where the field has sort of synthesized all the data. We take the lesson from Yamazaki that a higher dose per fraction works really well for glottic cancer biology, and we apply it to T2 as well. So modern practice has almost entirely shifted to using that same hyperfractionation schedule, 2.25 grade per fraction, for T2 disease.
Okay, so we're streamlining the approach.
We are. It's more convenient for the patient, it's less toxic than BID, and based on the biological principles, it's likely just as, if not more, effective. So that 2.25 gray really becomes the magic number for all early-stage glottic cancer.
That's a great pearl. It simplifies things, and it's based on the best evidence we have. Okay, let's put this all together into a practical framework. I like to call this the if-then risk ladder. I'll give you a clinical scenario, you give me the prescription and any key nuances.
Okay, let's do it. Fire away.
Scenario 1. The simplest case. If you have a T1A, single cord, no commissure involvement, the slam dunk.
Then you treat to 63 gray in 28 fractions. That's your 2.25 gray per fraction schedule. And you tell the patient you expect greater than 90% control.
Okay. Scenario 2. If it's still a T1, but now it involves the anterior commissure.
Then the dose is the same. 63 gray in 28 fractions. But your technique has to be perfect. You must verify your anterior coverage. You need flash, you probably need bolus, or you need to be very careful with your wedges. And clinically, you should know that the control rate drops a little. It goes from over 90% down to maybe the 85–90% range. The anterior commissure is a known risk factor for local failure.
And why is that? Why is the AC a bad actor?
It's two things. One is dosimetric. It's right under the skin. It's a very superficial structure, so it's easy to underdose if you're not careful. The second is biological. The thyroid cartilage is right there. And tumor cells may have an easier time permeating that cartilage right at the commissure compared to the midcord.
Got it. Okay, scenario 3. If we have a T2A, so there's extension to the supraglottis or subglottis, but mobility is still normal.
Then you need a little more dose and a bigger field. The prescription becomes 65.25 gray in 29 fractions. You have to make sure you expand your field border superiorly or inferiorly to cover that extension. Here you're expecting about 80% control.
So we just add one more fraction, one extra day of treatment compared to T1.
Exactly. That little dose escalation, that extra 2.25 gray, helps to account for the slightly larger tumor volume.
And final scenario, if you have a T2B, this is the one with impaired mobility, the sluggish cord.
Then the dose is the same. 65.25 gray in 29 fractions. But you have to recognize that the biology here is getting more aggressive. You might even consider concurrent chemotherapy in very select high-risk cases, though that's still controversial. And you should expect local control to be around 70%.
That dropped to 70%. That's a 1 in 3 chance of recurrence. That's significant.
It is significant, and it's why some centers and some trials have explored even higher doses or induction chemotherapy for these patients. But for now, the standard of care is still radiation alone.
There's one more really important principle we have to talk about when it comes to prescriptions, and that's time. Overall treatment time, or OTT.
Yes. This is so critical. You cannot let these treatments drag on. There's fantastic data from UCSF showing that an OTT of greater than 43 days is associated with significantly worse local control.
Why that specific time limit? What's happening?
It's that accelerated repopulation again. Those tumor cells are dividing.
Mm-hmm.
For every day you prolong the treatment beyond the plan, you lose about half a gray of biological effectiveness. It's a huge penalty. If you have a 1-week treatment break, you might as well have just lowered the total dose by 2 or 3 gray.
So the mantra is avoid gaps at all costs.
At all costs. If an interruption happens, the machine goes down, there's a holiday, the patient gets sick, you have to make it up. The standard way is to use BID fractions to finish on the original end date. You don't just tack the missed days onto the end. You have to respect the biology of the OTT.
So if a patient misses a treatment on Tuesday, you might treat them Friday morning and Friday afternoon to get back on schedule.
Exactly. You wait at least 6 hours between fractions, but you get that dose in on time.
Let's get into the how-to, the actual treatment techniques. It's funny, in this era of protons and IMRT and all this high-tech radiation, for early glottic cancer, we're going back to the classics. We're doing opposed laterals.
We are. Usually simple 2D or 3D conformal fields. And I want to be really clear here. IMRT is not the standard of care for early glottic cancer. Opposed laterals are strongly preferred.
So why stick with the old school technique here? Why not use fancy IMRT?
Because the glottis is a small midline structure that moves. When a patient swallows, breathes, coughs, the larynx moves up and down. Opposed laterals give you this beautiful, uniform, robust dose distribution across that whole area.
It's forgiving.
It's very forgiving. IMRT creates these incredibly sharp dose gradients. If the patient swallows and the cord moves just 2 millimeters, you could potentially miss the target with a tight IMRT plan.
Ah.
Opposed laterals are robust to that motion.
Plus, with IMRT, you're giving a low-dose bath to the whole neck, right?
Exactly. You're needlessly irradiating the carotids, the constrictor muscles, the spinal cord. Opposed laterals keep the dose tightly confined to that little box we talked about. It's the right tool for the job.
Okay, so let's design the field. For all the residents listening, get your mental pencils out. Let's start with a T1. What are the borders?
Okay, visualize the patient's neck from the side. Your superior border is the thyroid notch, the top of the Adam's apple. Your inferior border is the bottom of the cricoid cartilage. Anteriorly, you need to flash the skin by about 1 centimeter.
And flash just means you're intentionally shredding into the air in front of the patient.
Right, to make sure you have full dose buildup right at the skin surface. And then your posterior border is the anterior aspect of the vertebral bodies. You want to stay completely off the spinal cord.
And how do those borders change if it's a T2 with, say, some subglottic extension?
You just expand your margins. If it's extending superiorly, your superior border moves up to the hyoid bone about 1 centimeter above the notch. If it's extending inferiorly into the subglottis, your inferior border drops down to include 1 tracheal ring below the cricoid.
What about the beam energy? What are we dialing in?
6 MV photons. You should not use higher energies, like 10 or 15 MV.
Not.
Because higher energy beams have a greater skin-sparing effect. The dose builds up deeper in the tissue. That means if you use 10 MV, you will almost certainly underdose the most superficial part of the larynx, which is
The anterior commissure.
the anterior commissure. It's right under the skin. 6 MV brings that dose buildup closer to the surface and ensures that area gets the full prescription.
You mentioned wedges earlier. This is a classic physics problem. Why do we need wedges for a simple pair of opposed lateral beams?
So think about the shape of a human neck. It's not a perfect square. It's narrower in the front, at the Adam's apple, and it gets wider as it goes back toward the spine and shoulders. If you just shoot 2 open beams from the sides, the thinner anterior part gets less beam attenuation, and you create a massive hotspot right on the larynx.
So the wedges are there to compensate for the changing thickness.
Exactly. You put wedges on, usually 15 or 30 degrees, with the thin end of the wedge pointing forward. This holds back the dose posteriorly and evens out the dose distribution, so you get nice straight isodose lines right across the vocal cords.
But there's a huge risk here. This is one of those strong resident versus average resident moments.
This is a huge risk. The pitfall is over-wedging.
Yeah.
If you try to make the dose perfectly flat based on the external contour of the neck, you can accidentally pull too much dose away from the front and create a cold spot right on the anterior commissure.
The very structure we just said is a high risk for recurrence.
The very one. So you have to explicitly check your AC coverage on every single plan. You look at your 95% ocidose line. It must cover the anterior commissure. If it's looking a little cold, you have two options. You can reduce your wedge angle, or, what's more common, you can add a 5 mm bolus to the skin anteriorly.
And the bolus is just like a piece of wax or gel that you put on the skin to pull the dose forward?
Exactly. It tricks the beam into thinking the surface is 5 mm deeper, and it guarantees that superficial structure gets full dose. It's a balancing act. You have to accept a little bit of a hot spot in the anterior neck to guarantee you're not missing the cancer.
Perfect. And let's just formally close the loop on the neck. Elective neck treatment.
The standard of care is simple. You do not treat the neck for T1 or T2 and 0 glottic cancer.
Even though it feels so counterintuitive, given what we do for every other site, what's the hard data on that?
It comes from a massive series out of the University of Florida. They looked at their outcomes over decades and showed that the risk of an isolated nodal failure, meaning the primaries are controlled, but a node pops up later, is less than 5%.
So if you treat the neck just in case?
You are giving 96% of patients unnecessary toxicity, dry mouth, neck fibrosis, carotid dose to potentially benefit 4%. The toxicity trade-off just isn't worth it.
Are there any exceptions to that rule?
The only exceptions are if you have significant extension out of the glottis. If there's true supraglottic extension, you start to worry about levels 2 through 4. If you have subglottic extension of more than 5 mm, you start to worry about the level 6 paratracheal nodes. In those very specific cases, you might expand your fields to cover those nodal basins. But for a pure glottic cancer, no neck.
Fantastic. Before we jump into the controversies, I want to crystallize the main points with some clinical pearls. These are the things you should have on your mental flashcards for the boards.
Okay, let's lock them in.
Pearl number 1.
2.25. Gray perfraction is the winner for T1. That's the Yamazaki trial.
Pearl number 2.
Your T1 dose is 63 gray in 28 fractions.
Pearl number 3.
Your T2 dose is 65.25 gray in 29 fractions.
Pearl number 4.
No elective neck treatment unless there's significant extension.
Pearl number 5.
Watch the anterior commissure. It's a high-risk area. It often requires bolus or a wedge adjustment. Do not miss this on your plan check.
And pearl number 6.
Overall treatment time matters. Keep it under 43 days. Do not let your patients take a mid-treatment vacation.
Okay, perfect. Now let's wade into the big debate, the tumor board discussion. Radiation versus surgery, specifically transoral laser microsurgery or TLM.
This is the conversation you have every week with your ENT colleagues. And the first thing to say is that both of these are excellent options. Both achieve fantastic oncologic outcomes. The cure rates are, for all intents and purposes, the same.
So the debate isn't about curing cancer.
No. The debate is about functional outcomes. It's about the voice.
And we actually have a randomized controlled trial for this, the Aaltonen and Pakkanen trial out of Finland.
We do. It's a great study. They randomized T1A patients to get either definitive radiation or laser surgery.
What did it show?
Oncologically, it was a dead heat. Overall survival, disease-free survival, larynx preservation rates, all identical. You are not compromising your chance of cure by choosing one over the other.
But the voice, that was the tiebreaker.
That was the tiebreaker. The trial found that patients treated with radiation had significantly less breathiness in their voice and reported less hoarseness-related impact on their daily lives compared to the surgery patients.
And why is that? Why does the laser cause more breathiness?
Well, think about what the surgery actually is. The surgeon is using a laser to physically vaporize and remove a chunk of tissue from the vibrating edge of the vocal cord. You're carving out a divot.
So you're left with a defect.
You're left with a defect, a gap, and that can prevent the vocal cords from closing completely. If they don't seal tightly, air escapes during phonation, and that escaping air is what we perceive as a breathy voice. Radiation, on the other hand, treats the tissue in situ without removing it.
So the scaffolding of the cord remains intact.
Exactly. The cancer cells die off, but the underlying collagen matrix remains, and normal epithelial cells repopulate it. The cord stays plump and is better able to close.
So let's build a decision matrix for the listeners. When should you lean towards radiation and when should you lean towards laser?
Okay, you should prefer radiation if the tumor has diffuse involvement along the cord, if it involves the anterior commissure, which is very hard to see and get clean margins on with a laser, or if the patient's #1 priority is voice quality. If they're a singer, a teacher, a lawyer, a preacher, radiation is probably the better bet for their voice.
And when would you prefer laser surgery?
You'd lean towards laser if the patient really wants a one-and-done procedure and doesn't want to come in for 28 radiation treatments,
Right.
or if they want immediate pathologic confirmation of the margins. It's also a great option for very small, superficial, easily visualized lesions. And, it does keep radiation in your back pocket for potential future cancer.
That's a good point. You can always radiate after surgery, but doing surgery after high-dose radiation is much, much more difficult.
It is. So it really comes down to a trade-off between convenience and long-term voice quality.
Yeah.
And, of course, patient preference is a huge part of that conversation.
That's a fantastic breakdown. Okay, let's wrap up with a board blitz. I'm going to hit you with 3 rapid-fire questions. You give me the answer and the rationale oral board style.
All right, I'm ready. Let's do it.
Question 1. A 58-year-old male with a T1A N0 glottic cancer on the middle third of the cord. What is the best fractionation schedule?
The best fractionation is 63 gray in 28 fractions, delivering 2.25 gray per fraction. The rationale is the level 1 evidence from the Yamazaki trial, which demonstrated a 15% absolute improvement in 5-year local control for hypofractionation compared to conventional fractionation regimens like 66 gray in 33 fractions.
Question 2. Which of the following findings would indicate a need to expand the radiation field to treat the neck lymphatics? Anterior commissure involvement or subglottic extension?
The answer is subglottic extension. The rationale is that the subglottis has lymphatic drainage to the paratracheal and lower jugular lymph node basins, creating a significant risk of nodal metastasis. Anterior commissure involvement is a risk factor for local failure and affects local field design, requiring bolus or wedge adjustment, but it does not in itself increase the risk of nodal spread.
Question 3. What did the Aaltonen and Pakkanen randomized controlled trial show regarding the comparison of radiation therapy versus transoral laser surgery for T1A glottic cancer?
The trial showed that radiation therapy results in less breathiness and less hoarseness-related inconvenience compared to laser surgery. The rationale is that while the oncologic outcomes, including overall survival and larynx preservation, were equivalent between the two modalities, the functional voice outcomes favored radiation therapy due to the preservation of vocal cord tissue volume.
Perfect. Aced it. That brings us to our final summary.
Let's recap. Early glottic cancer is managed with single-modality therapy, either definitive radiation or transoral laser surgery. Staging is critically dependent on vocal cord mobility. Impaired mobility makes it T2, and a fixed cord makes it a T3. The optimal radiation dose is delivered with hypofractionation at 2.25 gray per fraction, typically 63 gray in 28 fractions for T1 and 65.25 gray in 29 fractions for T2.
Your field design is classic opposed laterals from the thyroid notch to the cricoid with an anterior flash, and you have to actively manage your wedges and bolus to ensure full coverage of that high-risk anterior commissure.
And remember, no elective neck radiation unless there's significant supraglottic or subglottic extension. And finally, for those T1A cases, you can counsel patients that radiation offers a better voice outcome, specifically with less breathiness when compared to laser surgery.
That perfectly wraps up episode 27, and we're going to tease our next session, episode 27B.
Yeah, next time we're taking this from the clinic to the planning room. We're going to pull up a contouring workstation, talk about simulation setup, and do a deep dive on 2D versus 3D versus IMRT planning. It's going to be a very practical, hands-on session.
Complete practice oral boards at radonfikeslearn.com and subscribe to Radon Smart Review for our next episode. Thanks for tuning in.